So in the first slide over here, essentially, this is given a general description. So why do PTs and PTAs need to know about integument? So first of all, if you think back to your what you've learned in your anatomy class, the largest organ that you have in your body externally would be skin. So again, recall that skin consists of both epithelial as well as connective tissue. And when you talk about the integument, it also includes the subcutaneous layer or fat. So both PTs and PTAs are also involved in caring for wounds. And in wound care, again, we're referring to not only burns, but also many patients, especially those that are bedridden, they have ulcers from pressures, complications, for example, from diabetes contributing to that, amputations that are a consequence of uncontrolled diabetes. In addition to that, you have patients where they have areas of excessive scar formation, or also areas where there's severe inflammation. As far as the layers of the skin go, again, please refer to your anatomy if you have forgotten about this, but essentially it consists of epidermis and dermis. So the outermost part and the thinnest of the two would be the epidermis. The stratum corneum, that's the most superficial layer, and the basal cell layer, this is the deepest layer, which connects to the underlying dermis. The epidermis is avascular. Again, this means there is no blood vessels that penetrate through the epidermis. And its main purpose is protection. This is the first line of defense that we have in your body that protects microbes and other pathogens from entering, gaining access to the deeper tissues. Certain parts of the body skin is thicker, other parts of the skin is thinner. So for example, under eye area, its skin is very thin over there. And again, this is why, if you don't get enough sleep, one of the things that you notice is you get these dark circles under your eye. Skin is really thin. Thick skin, on the other hand, again, if you look at the soles of your feet and the palms of your hand, these two areas, a lot of friction is present. Therefore, you will have thicker skin there. When we look at the dermis, this is going to be the innermost layer. Again, this consists of connective tissue. And it's within the connective tissue, there's a ground substance that's present. So blood vessels, nerves, your sweat glands, as well as sebaceous glands, including hair follicles, these are all going to be found in the dermis. Now, the subcutaneous tissue beneath the dermis, this is just your fat layer. And again, this is all that there is fat. So again, depending on the area of the body you're looking at, there's going to be different amounts over there. Some areas there'll be more, other areas there'll be less. And the dermis, again, it's there to bind to the deeper structures of the body. Moving along, so when you look over here in this picture, essentially what we have is you see the epidermis over here, and then you have the dermis here. And then below that, we have the subcutaneous layer, the fatty tissue. So again, over here in the epidermis, there's nothing there. Notice there's no blood vessels over here, no nerve endings here either. Essentially, the only thing that's passing through are hair follicles and sweat glands. That's it. Oil glands, as you see over here, they're connected by the two hair follicles. So oil actually gets secreted through the shaft of the hair. This is that basement membrane, by the way, over here. Now, the dermis, it's actually made of two parts as well. There's an upper and a lower portion. Again, this is you should refer to your anatomy to go over this. So you should know this very well, but at this point, since we're near the end of the term. Again, the nerve receptors also, they're found over here. So over here, again, you have the nerve endings that are found, and through these other cells, the nerve is able to connect. From here, there's other type of cells that make their way, that form a bridge between the epidermis and dermis. Now, in terms of wound healing, there is phases. All right. So during the first phase, the patients, they should address their wound. You should be addressing for them their wound care, management of swelling, edema, positioning them so that they're comfortable, splinting, and also using both cautiously passive as well as active range of motion exercises. They should, you should be ambulating them. In the second phase, again, you want to continue what you're doing in the first phase, but you can add to that stretching, strength training, as well as endurance. Again, you have to be cautious of the wound. Skin is very fragile. So yeah, these are essentially the two phases over here. So again, during the inflammatory phase, this is what ends up happening immediately after the injury. You end up having vasoconstriction to decrease the amount of blood that's lost. After that, after a clot has taken place after that point, then vasodilation proceeds. The edema that results due to the blood that's there, okay, from the tissue damage, this is one of the causes for pain as well as for the limited range in motion that could result. And usually within a couple of weeks, this is alleviated. The second phase, again, at this point now the body's it's repairing itself, it's healing during this point. So collagen that's produced by fibroblasts, they end up providing strength to that wound. The ground substance also starts to get relayed, and also you may have, in addition, you're going to end up getting new blood vessels that start to grow to that tissue. At that point, when nearly everything is healing, the wound will start to contract. So a little bit smaller, hopefully a little bit smaller. Now, during the maturation phase, again, in terms of therapies, you continue what you do, but you can be a little bit more aggressive at this point. So during this this remodeling phase, as it's called, again, there's a balance between collagen formation and how much collagen is being dissolved as well. So how well this goes is what's going to influence the scar formation. Now, excessive collagen, it ends up, when you have too much collagen that forms, this is what leads to abnormal or larger than normal scars. So there's a couple of different types. One of them is what's called this hypertrophic scar, and then there's the other one that's called the keloid scar. Now, they're both big. The difference is that a keloid scar, it starts to move beyond the area where the tissue is injured. So in other words, it goes and takes over into adjacent areas. We're not talking about how high or how low it is, but this type of tissue goes into healthy tissue as well, starts to grow there as well. Now, anytime you end up having any type of injury, you're going to end up getting a scar. It doesn't make a difference if a surgeon cuts or you cut yourself. There will be scar. Now, depending on which part of the body, and also depending on the person, scars, they heal differently. Some people heal much faster. Other people, they heal a little bit slower. Some people scar excessively. Others scar much less. Again, generally speaking, but not always the case, people that tend to have darker skin, they tend to scar much, much more than those that have lighter skin. Okay, and this maturation phase, again, it can last quite some time, several months sometimes. All right, so what else do you have to look at in terms of wound healing? So again, I told you one of the things, one thing that they don't have listed over here is diet. So if you're having a good, healthy diet, that's going to end up helping. And also, if you have good stress levels, low levels of stress, you meditate, you somehow manage to psychologically take care of your psychological well-being also, that's going to end up helping with wound as well. All right. Now, so aside from being not overstressed from life and eating well, and of course as a therapist, you're going to be doing the exercise. The other thing that goes along with that is the wound itself. How deep is the wound? Where on the body is the wound? What part of the body is affected by it? How large is it? Not only how deep, but how large. So again, we look at this over here. Let's pause here. Look, the back accounts for about 9%. Front is about 9%. Each arm is about 4%. The front and back, both the front and back of the head are 4.5% each. As we move on to the legs, both front and back are about 9%. The genital area is 1%. So what this says, again, the larger the wound, it's going to take a much longer time to heal. What else is disrupted? Aside from the damage that's there, what other type of tissues involved? So all of that, will determine how good the patient will recover from. All right, in terms of vascular compromise, first of all, there could be arterial insufficiency. So again, this is just, as the name implies, not enough blood vessels, not enough oxygenated blood being delivered to a specific tissue by way of the arteries. Going along with that is also venous sufficiency. Now, this means that not enough blood is being removed from the tissue. Remember, veins move blood away, they take it back to the heart. So if you're not able to remove enough tissue, that means, blood starts to accumulate, you end up having more swelling. Now, pressure ulcers as well. Now, pressure ulcers, they can also reduce blood flow. Once that happens, then tissues start to die. Why? Because they're not getting their nutrients, they're not getting, oxygen as well, and they're not getting the waste products from them, so this starts to accumulate. The tissue starts to rot. There's also neuropathic ulcers. So again, neuropathic ulcers, you don't feel anything. So it's insensitivity of the skin. Again, when you don't feel anything, then you tend to not move, and that just makes this pressure much worse. Or again, if it starts off as neuropathic compromise, it ends up turning into a pressure ulcer as well. Moving along, what do we have? All right, so what are some of the common areas of the body that are susceptible to pressure ulcers? So if you look over here, so if you're sitting up, if you're seated, then your elbows, spinous process, sacrum, coccyx, the ischial tuberosities, greater trochanterals, and the heels. So these points, these are the most prominent points. If you think about it, someone that's wheelchair bound, this is where you're going to see them, all right? Someone that's lying on their back, okay, they're bedridden, it's going to be the occiput, right? In addition to that, elbows, again, scapula, the spinous process, sacrum, coccyx, heels. Why? Because all these are constantly on the mattress. So again, when patients that are bedridden or patients that are in a wheelchair, they need to be constantly moved. They need to reposition so that they don't end up getting pressure ulcers. If they're on their side, then again, what parts are most prominent on the side? Very easy. Look at yourself. Ears, shoulder, elbow. Again, the greater trochanter. Both the medial and the lateral aspects of the knee. Why? Because again, one side of your other leg that you're not, the side that you're not lying down on, that part of the knee is going to be pressing against your other knee. So there you go, the medial as well as the lateral aspects of your knee. The lateral aspect is going to be the part that's in contact with the bed. Also, medial and lateral malleoli of the heel as well. If the patient is prone, then the areas that are most susceptible to ulcer formation, pressure ulcer formation, would be the forehead, the nose, the chin, the front part of your shoulders, the iliac crest, patella, and again the dorsal surface of your feet as well as toes. Why? Once again, these are the parts that are in most contact with the bed or the area that they're laying down on. Now, trauma can lead to decreased sensation as well. Again, ischemic, it could be a decreased sensation. Again, we also call that ischemic sensation. So ischemic sensation, it could lead to trauma as well. So it works both ways. Trauma can lead to decreased sensation. If you have ischemic sensation, then that can lead to trauma as well. So generally speaking, again, decreased sensations that prevent individuals from adjusting themselves. So think about, a pebble in your shoe or a hot plate, you touch it, you don't feel anything, you continue to deal with that. What's going to end up happening? It ends up leading to tissue damage. So as a physical therapist, what do you want to do? Well, you want to get the history of your patient, obviously, during your examination. Determine the cause, the depth, the size of the wound, and also see if there are any signs of infection. Check the area around the tissue for damage. So again, you're looking at, if there's sensation, does it feel hot when you palpate? Is there any hair growth there? Are they able to move around? How about also you want to look at pliability? What about what it looks like? Is it white? Is it blue? Is it black? What about the texture? Is it smooth? Is it rough? So you want to look at all these things on the skin. Aside from that, you end up doing the full evaluation of your patient. So you check for, examine their communication, as well as their comprehension. And you look at their strength, look at mobility, et cetera, et cetera. Now, when you look over here, this is showing arterial wounds. So what do we see in an arterial wound? We're looking at, again, this is a foot over here, all right? So commonly found in lower parts of the leg. Again, these tend to be dry, so there's no exudate that's going to be present. When you look at the shape, it's irregular. Again, often it will look pale in color, and they tend to be deep as well. These are very painful. So again, if you want to look at severity of pain, it's quite severe. Okay? When you move, it ends up increasing. The skin adjacent to the wound is also pale. Again, when you touch it, it's cool. You're not going to find any hair. And it will look then, guys, the skin is dying, essentially. That's what it is. You may not, if you search for a pulse, probably won't even find that. This is pretty bad. Now, when you look at a venous ulcer, this is going to be in the lower part of the leg. Now, in a venous ulcer, there is exudate that's present as well as edema. It also has irregular shape to it. However, this is going to be shallow, whereas the arterial was deep. This is going to be shallow. If you look at the color, it'll be red or pink. Again, the swelling, unfortunately, it contributes to a decreased rate of healing. And overall healing it's not very good. It's very difficult to manage, and it takes a very long time. Pain, it tends to be mild. Again, it does tend to decrease when you raise it, when you elevate it. The adjacent skin, the area around it, as you can see in this photograph, it is inflamed. Okay, so you're going to see there, the veins also end up being dilated at those points. You'll see pigmentation and abnormal pigmentation. Again, you can see that present over here. And also you'll feel, if you were to feel on this, the tissue, if you were to palpate, it would be hard. And as well, there's evidence over here. You can see that the skin is rather dry over there. So when you check for distal pulses, you will be able to feel for that. So that's palpable. All right. So is there anything? All right. So as far as treatment for this, so again, you want to clean the wound. The wound is cleaned when the dressing is changed. Normally, with ordinary tap water, it's more than sufficient. Again, the aim is to contract that raised pressure in the leg veins, and this is what's going to give the best chance for the ulcer to heal. Common methods for a physical therapist or a nurse is to put on about 2 to 4 layers of bandages over the dressing. And when the bandages are put on, the pressure is put highest at the angle and gradually less towards the knee and thigh. You want to try to keep the legs raised higher than the hip. Now, this is important if the leg is swollen. So again, the aim is to let gravity help to pull the fluid and blood in the proper direction. Again, that's towards the heart. So what this is going to do is that it's going to help reduce the swelling in the legs, as well as reduce the pressure of blood that's collecting in the leg veins. So try to set like 3 or 4 periods per day of about 30 minutes to lie down and again to have the legs raised. The other thing that's important for this is, if the patient is smoking, try to have them stop smoking. If you're a smoker, the chemicals of cigarettes, they tend to interfere with skin healing. Antibiotics, they're sometimes advised for short periods if the skin and tissue around the ulcer becomes infected. As far as for pain management, painkillers, they can be taken if the ulcer is painful. As far as skincare goes, now as for the skin around the ulcer, usually it's often inflamed, and again, it's dry, it's scaly. So a lot of time, you may end up, you may have an order from the doctor that would advise for the nurse or for the physical therapist to apply cream to reduce that inflammation, topical creams. All right, remember, nutrition is very important as well. So if your diet is not very good, and if you're obese, you're overweight, then starting to eat healthy and also losing weight is going to help also. Obesity is it's a risk factor for developing venous leg ulcers. Sometimes, they also recommend in terms of diet, iron tablets if you're anemic. So as I said, the healing period is very slow for this. Maybe 12 weeks or so it takes for, again, so you're looking at about 4 months for healing to occur. Unfortunately, venous leg ulcers, they commonly recur after they've healed. Again, in order to prevent this, you should wear these compression stockings during the daytime. This seems to help a lot. And again, this should be done for at least 5 years until after the wound has healed. Now, when we talk about neuropathic ulcers, the ulcer is secondary to the insensitivity. This is why it's called a neuropathic ulcer. So the decreased sensation in the decreased amount of sensation, it limits that person from making the adjustments that they should be throughout the day. So again, this sensory loss, which tends to occur in the soles of the feet, especially in patients with diabetes mellitus, type 2 diabetes, they may notice a small rock in their shoe, all right? But they may have been walking on there for God knows how long. So what ends up happening, blood flow by that tissue ends up being compromised because that pebble, it decrease, again, that pebble that's there, it's pushing up, all right? Now it's causing a decrease of blood to flow. Over time also, again, just that pebble pushing in, it's gonna end up causing other types of trauma or damage as well. So this is what bad things are dangerous. Now for pressure ulcers, once again, they're commonly, you're gonna find them over bony prominences. Their sizes also, they vary. So if you look, different, like this is actually showing healing, but again, different individuals, they will heal at different rates. And again, the larger it is, it's gonna take much more time to heal. So again, when you're looking at the different stages of the ulcer, so if you look over here, stage 1, 2, 3, and 4, what's the difference? Stage 1, this is the best case scenario if you want to look at it, and the worst would be stage 4. So in stage 4 ulcers, now there's full thickness tissue loss. So you can see bone, muscle, and tendons for that matter. When you look at, when we're talking about, all right, so moving on to trauma. So initially, again, when someone has any type of trauma, they need to go to their primary medical care provider. So, and depending on the type of trauma, if it's severe, then they may have to go to the emergency room or trauma center, or in certain cases where this is not available, they will have to go to their general doctor. And again, traumas, they could occur from anything. And again, the severity also ranges from, abrasions all the way up to burns. So again, this level also, it varies. Avulsion, this is when there's a big mass of tissue that's missing. Burns, a lot of times burns are considered to be trauma as well. So burns, not only could they be from fire, but a lot of people don't realize that burns could also come from chemicals, from scalding, from radiation, even from electric, or again, other thing is cold. Cold can also cause burns as well. So the severity of the burn injury depends on the total body surface, okay, that's affected. Aside from that, same things that we saw before that we looked at a handful of slides ago, they apply as well. So location, depth, if there's any other trauma that's associated with it, all these are going to end up affecting how severe that trauma is. So when you talk about, diseases, so again, physical therapists and PTAs, they have to recognize certain, not all, but certain signs and symptoms of skin cancer. So if there's a new lesion, if a wound, for example, is taking more than 3 months to heal, then again, you may want to start thinking skin cancer. Or again, for moles, okay, or a nevus, a mole. If there is a change in the mole. Now, a mole, a lot of girls, especially, you call it a beauty mark. A beauty mark, if it's changing in color, in its size, or shape, then this is something that you need to be concerned about, okay? So all these things, you have to be aware of. Again, we talked about scar tissue as well. Again, scar tissue is it's evaluated on this Vancouver burn scale, and it ranges from 0 to 5. And what are the bases for this? Vascularity, its pliability, the height of the scar tissue, as well as pigmentation. In addition to that, location is also very important. Just as in real estate, again, if that the location of that scar is over a joint, it could impair movement severely. So when you look over here in this child, unfortunately, you can see a very large percent of his body has been burned. Probably this looks like the result of a scalding injury. He may have been looking upwards, luckily upwards, so his face didn't get affected, but maybe in the kitchen, a hot pot of water, he may have pulled it and it fell down as he was looking up, it hit his neck, and then it spread all over. So again, now the most painful parts are going to be at the joints, okay, because the scar tissue is going to restrict the movement over there. It's not very soft. It's not very pliable. So the physical therapists are going to complete a detailed evaluation, and this detailed evaluation includes assessment of the condition, any related impairments, what level of functional loss there is, overall general health, as well as social factors also need to be determined by the physical therapist. The prognosis is going to be dependent upon when the wound is stable, if it stays clean, how it's healing, or if it's healed already. And also, again, you want to look at the potential scar in this. So, excuse me, your goals and plan of care should be based accordingly. So, what about for intervention? What could be done? Well, again, an ounce of cure is worth an ounce of prevention is worth a pound of cure, as they say. So prevention is essential especially when patients are at risk for pressure ulcers. What does that mean? Give an example of that. Well, think about it. You have a type 2 or type 1 diabetes mellitus patient, and they're bedridden or they're on a wheelchair. That's a red flag right there. So these individuals, you want to start preventing. How? By making sure that they reposition themselves enough, by checking their shoes, making sure you change and inspecting areas on their feet between the toes, being careful when cutting nails, and again, having weekly checkups in the extremities especially. Why? Again, because the leg and feet are the most common to be affected. Now, when it comes to wound management, again, arterial and neuropathic ulcers, for arterial neuropathic ulcers, again, it's important to keeping that wound clean. Okay, so that's achieved through cleaning, applying dressings and topical agents. Also, a lot of times it helps to maintain moisture at the wound. Now, for venous wounds, compression, you want to use compression, as we said before, compression stockings, socks, and positioning that'll help reduce the swelling. For pressure ulcers, again, wound care and pressure relief. These are the only two things you can do. You have to keep pressure off, additional pressure off that area, and keep cleaning that wound. Exercise that you prescribe, it should emphasize joint mobility. Aside from that, muscle performance, gait, ventilation, as well as circulation. If the patient's not able to move independently, then the body should be turned. You have to. So again, people that are comatose, or again, people that are paralyzed, you need to reposition them every 2 hours. This is very important to do. Extremely important. I can't stress that enough. The consequences, guys, it's horrible. I've seen it firsthand in patients, especially those that are bedridden. And God protect us all from that. It's horrible stuff, horrible stuff. Once you see that, you won't forget, especially the amount of pain that these individuals have. All right. So now scar management. Scar management, you have to monitor the scar contractions in order to avoid scar contracture. All right, you can't let it get widened. This is what you have to do. And again, this is also why you have to be careful in terms of the stretching, okay? Passive and active stretching. So splinting is very important, positioning is important. So anti-contracture positions, such as an extension for the elbows or neutral in the ankles, this is gonna help. Again, the use of pressure garments also help. So again, they're just kind of showing you like what are some of the things that you can do to help with that. Again, using towels to soften the area over here. And again, you see this individual has got these pressure stockings on around his arms. So this individual looks like a burn victim. The last thing that's over here that's very important is patient education. So patient education should be focused on, actually, no, it's something that the entire team should be focused on. Right? You have to include the caregivers of that individual as well. What do you teach them about? Well, you teach them about skincare, wound management, positioning techniques, exercise programs, putting on pressure garments. All of these things must be visited and told and taught to the patient or the patient and the family members, or again, whoever the caregivers are for that individual. Right. So this is it for the unit on the integument. So let me close this, and we'll start the next unit. Okay.